invite Dr. Puxty forward to speak to you around the alignment of rehab best practices with our Southeast Restorative Care Clinical Services Roadmap. You'll see that Dr. Puxty's bio is extensive, so we're calling upon all of that expertise, as well as his role as co-chair and regional lead for the Restorative Care Clinical Services Roadmap.
So welcome, and it's wonderful to see so many people here, and so many people actually from across the region who are recognized, and so many other people who actually contributed to the clinical service roadmap in restorative care. I'm going to run through the first few slides fairly quickly because we have a limited amount of time. But as was just indicated, clearly I think people know we have a crisis around patient flow. It's an ongoing issue for us. We're all aware of issues around gridlock. We're aware of issues of high AOC rates. Even though we've seen improvements in this region, it's still higher than we'd like it to be. We see pressures in our emergency room. We see pressures in our acute care. We know that there are a number of factors that contribute to this, and we need to look at the systemic issues, at roadblocks. We need to understand what these roadblocks are and understand the implications of not responding to those roadblocks by removing them, and what actually we will gain by facilitating the transfer and flow of patients. We need to look at the potential opportunities and the solutions. Some of them will be easy, some of them will be hard. But we need to remember our focus is the best outcome for our patients that we serve. The clinical services roadmaps, there actually are 7. The process started, it's only actually just over 2 years ago. It seems much longer for those of us who have been involved in it. It's a very exciting process with the leadership of the LINs, with the support of CEOs, with the support of the chief nursing execs, chiefs of staff, and the boards of the associated hospitals, CCAC, and Queen's. We've been able to make tremendous moves forward in terms of starting the process of integrating care in several areas. And I believe Southeastern Ontario is the provincial leader in this process. And you're going to hear more about it as these clinical services roadmaps move out into your communities in the next year. My focus is the restorative care roadmap. I just want to say, whenever you think rehab, think restorative. Whenever you think restorative, think rehab, because they're together. This is an integrated strategy that links rehabilitation, geriatrics, complex continuing care, long-term care, community care. All those things that are intended to improve functional outcomes of our patient population. There are 5 main components to the clinical service roadmap in terms of restorative care, and I'm going to quickly take you through all 5. Primarily just to make you aware of them, and the slide deck is really a reference for you later on. There's a lot more information available, and we can supply that. One of the issues we know is that there is a high-risk profile. There are individuals who account for a lot of the actual hospital and ER use, and a lot of the, and themselves suffer a lot of the adverse outcomes. They typically are female, living alone, very old, functional problems, diagnoses such as dementia, depression, problems of communication, and having caregiver or resource issues and challenges. There have been a lot of tools that have been talked about in the literature which have tried to help us define those individuals. Because although we all know what those individuals are, and we can easily identify them as potential AOC problems, GOMAs, get them to my emergency room, geriatric problems, social problems, we don't necessarily link them to the services that they need. So there's been some recent research which Southeastern Ontario is going to be a leader in bringing out into the communities around the use of a tool, the assessment urgency algorithm, which builds on some of the Interride data sets that many of you may be aware of. And really, just to capture it to you, is that the key message is, if people over the age of 75 and other age groups, but particularly over the age of 75, have functional problems around the ability to bathe, to ambulate, to dress the lower body, or personal hygiene, and there's perceived stress by either caregivers or the individual themselves, those individuals are high risk. And if you apply that to 75-year-olds coming through the emergency room, it'll pick up the 35% for a high risk of ALC, longer lengths of stay, returns to the ER, and repeat hospital admissions over a 3-month period. And even more important, that population has been shown, if you change the way we respond, you can alter outcomes in 40% of them, which would have a huge system impact. Since this group accounts for 40 to 50% of the utilization of health services over a 5-year period. We know that individuals coming into hospital with non-rehab core diagnoses, these are not strokes, these are not fractured hips, not rheumatoid arthritis, that individuals with diagnoses like heart failure, MI, pneumonia, over the age of 65, will suffer a 30% decline in function during the admission. Those of us in rehab and geriatrics talk about this as a secondary functional loss, an avoidable functional loss. We know that there are strategies that can actually avoid some of this, not the least of which is having leadership, having board and senior leadership recognition of this and empowering their staff to move forward, ensuring staff are trained, ensuring the best practices around things such as falls, delirium, pressure sores, avoiding functional decline are actually being utilized. Here's the bad news. Only 45% of hospitals in Ontario actually have what we consider the minimum best practices in place, if you list those best practices. 45%, more than half, fail. Creating physical environments that are supportive. In other words, making sure if a washroom is accessible to a wheelchair, it's also accessible to someone with a walker, it's accessible to a therapist who actually works with the client. So it's having environments which enable and restore. And taking every opportunity when we go through structural redevelopments, whether it's a minor or a major, such as building a new hospital, that we incorporate these principles. And they're not just for people over the age of 65, they're exactly the same principles you need for a 45-year-old with a stroke. Promoting the right attitudes, getting rid of these stereotypes, bed blockers, ALC patients, donors. That creates the problem, it doesn't solve the problem. And support and transitions in care. We're going to talk a lot about the move of people through the system, so that people can move through as need, acute care, rehab, slow stream rehab, community, and back as the need occurs. But those transitions are often fraught with problems and confusion and a lack of information in the present system. We're particularly in this particular community and in this conversation, and we're talking a lot about the standards for access and delivery of what we term formal restorative care within the Restorative Care Clinical Service Roadmap. A lot of it is captured in the top of the roadmap over to the side there. We're also going to be talking, I think, about some of the programs that we need to build in complex continuing care, long-term care, and community. In terms of new roles, we're moving away from the idea of complex continuing care and long-term care as a destination site. We're moving more towards the idea of transitions and restorative rehabilitation. The final part of the Restorative Care Clinical Service Program, I just want to flag, which actually is going to roll out in this community in the early new year, is the idea of an enhanced community communication capacity, a program called ICAR. Those of us that were involved in the original Restorative Care Program development refer to this as the hub. It'll be a resource that health professionals can call, can ask for advice and recommendations. It'll be operated jointly through CCAC and community supports. It will include the capacity to link navigators who will come to the home and help with the assessment and recommendations. So it's going to be a very hands-on process to help healthcare providers move people through the system. Timing, we're actually in the wave 1 at this moment. So in fact, we're moving forward with the high-risk identification tool in the early part of 2013. The pilot sites will be Lennox and Amington and Brockville, the General Hospital. We're actively, as I mentioned, implementing the iCart, and staff have already been hired. The process has been put in place. We're involved in detailed discussions and planning for implementation of senior-friendly principles within the hospitals of Southeastern Ontario. We have engaged conversations in the hospitals and the community around what new services need to be created in terms of, for example, slow-swing rehabilitation within complex continuing care. And we're moving forward in the early part of the next fiscal in terms of the detailed planning of what we're talking about today. So this is an important diagram we want you to reference. The important point about this diagram, I think, is you don't want people to take the bottom route, because they're bypassing all of the rehab and restorative. So as long as people are identified as unsuitable without actually being assessed or referred for potential rehabilitation or restoration, we're going to see bad outcomes. And those people will keep on coming back into the system with increased intensity of need. They'll be the walking wounded. So there's a lot of alignment with the things we're going to be talking today in terms of best practices around rehab and stroke as the indicator condition. And it links very much into the clinical services roadmap. And I'd just like to thank you for this opportunity to do a little bit of advertising of what's coming to your community in early 2013.